Coping depends on appraisal, a threat or a challenge. If the illness is viewed as a challenge, primary appraisal, and they believe they have a lot of social support, secondary, they will probably have higher quality of life. There is some evidence that those who employ multiple strategies may cope better with stress of chronic illness than those who engage in a predominant style. Active coping efforts seem to be more consistently associated with positive adjustment than avoidance strategies, as long as there are aspects of the disease that are controllable. Goals are important. If the patient expects to live life to the fullest, even in the face of illness, he or she is more likely to use active coping and fare better. Information avoidance is any behavior intended to prevent or delay acquisition of available but potentially unwanted information. This can be active, asking someone not to reveal info, or passive, by failing to ask someone a question that would reveal info. It is not limited to information about self. Over half of the subjects in one study said they'd not want to know if their spouse had a genetic vulnerability. It can be temporary or permanent. People may avoid information with the intent to learn information later, or they may decide to avoid information altogether. 3 reasons to avoid. The information may demand a change in beliefs. There are 3 types of beliefs: beliefs about self, others, and their world. Information may demand undesired action. If you learn you have Huntington's, for example, you may decide that you should not risk having children and passing on the gene. A research example. A study of commercial sex workers and their clients in South Africa revealed that one reason given for not getting tested for AIDS was that a positive result would demand a change in behavior. The primary reason women in Nigeria gave for delaying visits to their doctor about a lump in the breast was a concern that they might have to undergo a mastectomy. The information itself, or decision to learn information, may cause unpleasant emotions. People may avoid for more than one reason in a situation. People avoid information in the following scenarios: when they perceive less control, when they don't believe they can cope. Women who avoided info about their breast cancer risk reported less ability to cope with the information than counterparts who sought the risk information. When it is difficult to obtain and or hard to understand or interpret. Expectations. How expectations influence decisions to avoid or seek information is unclear. Sometimes people seek information when they expect it to be bad. For example, women who report feeling at high risk for breast cancer were more likely to have regular mammograms. Those who perceive high risk for a genetic condition are more likely to get tested. At times, knowing less may be better, but at other times knowing less can be hazardous, parallel to denial and an area for further research. Diagnosis of chronic illness changes self-perception. A loss of personal control and threats to self-esteem are 2 major changes. Fife in 1994 studied cancer patients. Understanding the meaning of their illness on a personal level was an important part of their coping. Some found positive as well as negative aspects. None remained as they were before diagnosis. Dunkel-Shetter also studied cancer patients. Those who experienced the least emotional distress tended to seek social support and to try and distance themselves from the illness. Those who were distressed wished the illness would go away and used drugs, alcohol, or food. They may have had a hopeless attitude toward the condition. Despair reflected in relation with their physician. Patients with acute disorders are not likely to challenge medical authority, but those with chronic illness frequently question the doctor's knowledge and or competence, perhaps because they believe he or she should be able to cure them. Such challenges can result in non-adherence. Support groups exist, but they appeal primarily to white middle-class women, and therefore the bulk of research on support groups is not very generalizable. A study was conducted with married couples where one partner underwent kidney dialysis for renal failure. Couples with flexible roles adapted better. One woman, used to being submissive, failed to get medical help when the husband became unconscious and died. Chronically ill parents may lose authority to discipline as part of the sick role. Or the parent may be protected from children's misbehavior because of the illness. Young children may feel guilt because they don't understand that their misbehavior was not the cause of their own or their parents' illness. Until approximately age 7, they're egocentric and think the world revolves around them. Families of sick children tend to be emotionally and physically fatigued. This can lead to marital problems and sibling jealousy. Sick children can become overdependent and/or manipulative if they do not get their way. A lot of research is focused on caregiving of Alzheimer's patients. Recall the risk of Alzheimer's increases with increasing age. In other words, the biggest risk is age. Caregivers are more distressed, show poorer immune response, and developed more infectious illnesses compared to the control group. Caregivers of Alzheimer's are more depressed, have lower life satisfaction, have less efficient wound repair and negative reactions to the flu vaccine, have impaired NK cell function. Daughters or daughters-in-law are called on by parent caring for spouse with Alzheimer's to help more often than sons or sons-in-law, whose assistance is usually in the form of helping wives or sisters. Men receive more assistance from their children in caring for wives than women receive in caring for husbands. Caregivers who are more depressed and or angry are more at risk for adverse effects on their immune system. Immune alterations can persist long after the end of the stressful situation when the person is deceased. Caregivers who received positive support had better immune function than those who received negative support, such as criticism regarding how they provided care. A 12-month study of family Alzheimer's disease caregivers found 2 predictors for depressive symptoms: behavior problems in relative higher objective stress, and caregivers who felt overwhelmed and trapped by the role, higher subjective stress. Women in caregiving roles report more depression, perhaps because of a loss of reciprocity in their relationship, meaning shared meaning and common activities. Maybe a more important dimension for caregiver wives. Hooker in 2000 compared caregivers of a spouse with Alzheimer's disease and Parkinson's. Women caring for a spouse with Alzheimer's had higher levels of perceived stress, anxiety, depression than did caregiver husbands. No gender differences among caregivers of a spouse with Parkinson's, which could be due to fewer reciprocity losses. Researchers have focused on benefits of caregiving. Can you think of any? They have found that caregivers reported gains in personal efficacy, mastery, enhancement of well-being, and self-worth. Sanders in 2005 found that only 19% of caregivers of Alzheimer's reported only strains. Most found positive aspects. Note, there are a number of chronic diseases mentioned in your text. We will briefly overview one. You need to read about the others: diabetes, HIV/AIDS, etc. Asthma. Asthma is highest among Native Americans. Second is African Americans, then European Americans, and finally Asian Americans. Note, ethnic minorities report higher use of emergency rooms. Why might this be? Perhaps the cost of medications may be prohibitive. Possible explanation for the rise in asthma is the hygiene hypothesis. This hypothesis states that modern society has become so clean that the immune system of infants is not prepared to fight off bacteria. Exposure results in over-responsiveness.